Hello, I'm Jim Sachetta, and today is Global Surgery Day. I'm joined by Dr. Alex Haynes, the Associate Director of the Safe Surgery Program at Ariadne Labs, a surgeon at MGH and Harvard Medical School. And we're here today to talk about the recent publication in the Annals of Surgery that is a continuation of our safe surgery work here at Ariadne Labs. Thank you for joining us today, Alex.
Thanks, Jim. Glad to be here.
So this recent publication is a continuation of work that's been going on for nearly a decade. Can you tell us a little bit about the history of that work and what's led us here today?
Absolutely. So this work all goes back to over 10 years ago now to the World Health Organization Safe Surgery Saves Lives campaign. Out of that work was born the WHO Safe Surgery Saves Lives checklist that has since spread to many parts of the world. In the context of that original development of the checklist, we ran a pilot study in 8 countries around the world and showed that in a fairly focused research setting that implementation of the checklist was associated with reduction in mortality and complications after surgery. However, as the checklist has rolled out into the real world, it's become quite evident that actually realizing these benefits in a real-world environment is more complex, and that simply having the checklist available is insufficient to realize those gains. And so we have built a set of programs to try and explore how we can best implement and integrate interventions like the checklist into surgical safety around the world.
And that involves a lot of the work in South Carolina and the Safe Surgery 2015 South Carolina project. That's where this publication was focused. Can you tell us a little bit about what the goals of that project were and also maybe the results that have come out recently?
Absolutely. So the Safe Surgery 2015 program in South Carolina was a collaboration between Ariadne Labs of the Harvard T.H. Chan School of Public Health and Brigham and Women's Hospital, along with the South Carolina Hospital Association and a variety of other stakeholders in South Carolina. And what it was a collaborative that came together to look at ways of integrating checklists and checklist-based programs into the operating rooms across the state of South Carolina in order to improve the quality and safety of surgery within the state. We recently published in the Annals of Surgery our results looking at the trends in mortality in South Carolina over the last 5 years, and looking at how those mortality trends changed around the time of introduction of the program. More specifically, we looked at the cohort of hospitals that had completed the program as of the end of 2013 and compared those to the hospitals which had not. And what we saw is that there was a trend in reduction of mortality that occurred in those hospitals, in fact a very significant trend, with a 22% reduction in mortality compared to the hospitals that did not did not complete the program. We went backwards to look and see if we were just capturing pre-existing trends, but there was really no difference in the trends in mortality prior to the intervention, and you start to see those trends separate as the program rolls out.
And these sound like really important findings. Can you talk about what that means for surgery globally and domestically?
What these findings show is that for the first time, we have been able to show scalability of the checklist, where that in a setting outside of a tightly controlled research environment, that we're able to roll out the checklist at large scale and realize some of the same benefits to mortality that we saw with our original work. What this begins to fill in the picture of is what do we need to do to make the checklist work in individual environments? How can we build collaboratives of multidisciplinary leaders at hospitals and empower them to introduce the checklist in a meaningful fashion? One of the key steps in this work was engaging leaders in, not just in surgery, but in nursing, anesthesia, surgical technologists, and others in the hospitals to really be leaders and champions for the checklist. And that kind of approach can really be effective not just in South Carolina, but around the world. We also began to accumulate some learnings around some of the steps that we can take, measuring culture in the operating room, which we know is a really key part to checklist implementation, and really focusing on the communication and teamwork as really essential elements of the checklist.
Well, this is very interesting and important work. Can you tell us a little bit what may come of this work and what the future of the Safe Surgery program may look like?
Yeah, so with our learnings from South Carolina, we've put together an implementation toolkit that's available on our website as a PDF form. We feel that these tools can then be taken to help implement the checklist in a variety of environments. We continue to work with organizations like Lifebox that are trying to implement the checklist, and particularly in low and middle income countries, to really modify the implementation materials and really find the levers for this kind of implementation in those environments. One of the key lessons that we've learned from our work in South Carolina and elsewhere is that in order for implementation to work, it really has to be integrated with the workflow of the individual environment. And the more that happens in the upfront period, the more likely the checklist is to stick, and the more likely it is to have the impact on patient outcomes that we seek.
Sounds like a very important lesson, and it seems like there's a lot more to be done. I think that's all the time we have today. I'd like to thank Dr. Alex Haynes again for joining us on Global Surgery Day, and we hope you have a wonderful day.
Thanks, Jim, and thanks, everybody.